So next is Down syndrome. So Down syndrome, most of us are pretty familiar with. It's relatively common, about 1 in every 730 live births. These individuals, by definition, just have an extra 21st chromosome within their cells. One of the biggest risks for individuals to have a child with Down syndrome is the mom is advanced maternal age. So beginning at age 30, progressively the risk of having an infant with Down syndrome increases each year. By the time you get to 40, it's pretty significant of a risk at that point. So the older the mom, the older the egg, the less stable the DNA material is, and the more likely that pregnancy may have an infant that has Down syndrome. Once again, there is a great continuum with these. So some are mildly affected, some are significantly affected by the condition. A lot of times you'll see intellectual disabilities, some significant altered facial features, which we're going to look at here in just a moment, which are some hallmark signs and symptoms. The goal for these, again, are support their growth and development, keep them as healthy as we possibly can, and allow them to have a normal life as much as possible and be able to support them in that. One big thing with Down syndrome, or individuals with Down syndrome, are to manage potential complications. So about half of babies that are born with Down syndrome are going to have some sort of cardiac defect. Sometimes they're pretty significant. So to be able to recognize those early and to seek treatments for those would be important. About 60% are going to have some sort of hearing or vision issues. Sometimes that can be retinopathies. It can be glaucoma in particular. With hearing issues, a lot of times they will have chronic ear infections that can lead to scarring and hearing impairment. And so, treating those aggressively, monitoring for those would be important. Obstructive sleep apnea. So half to 2/3 of patients are going to have issues with that. We're going to look here in just a minute. They tend to have an enlarged or protruding tongue, which will impact that airway during breathing or during sleep. And so that can certainly lead to issues with obstructive sleep apnea. So it may be that these individuals need CPAP. And then they are at an increase for infection risks as well. So something else to keep in mind if you're taking care of a patient. So the way we diagnose these patients is through a first trimester screening, which is optional, but moms may choose to have blood work done and ultrasounds in that first trimester to look for markers related to Down syndrome. It is a screening, it is not a diagnostic tool. So they are given a probability of, 1 in 2,500 chance that this baby is going to be born with Down syndrome. So not every mom is going to have that. It can bring up some ethical issues, some emotional concerns for these moms if they have the screening or don't have the screening. But you may have some patients that you'll see that have had that screening. If at birth, nurses or the physicians observe certain characteristics or physical characteristics that are common with Down syndrome, then a lot of times then they will send genetic studies. It takes a little bit for those genetic studies to come back. So patients can be antsy and really want to know, and sometimes it can take a little bit. It can be delayed. So it's not something that's going to come back overnight. So that's a high stress time for patients and the parents of that infant. So at delivery, if you work in the neonatal intensive care unit or labor delivery or postpartum or the nursery, you'll become pretty familiar with what some of these signs and symptoms are. So a lot of times the nasal bridge is actually lower. Sometimes they'll have lower onset or lower eyes. Remember we said the outer canthus should be even with the top of the ear. So sometimes they will actually have lower ears. Sometimes the auricle of the ear can be have some abnormalities. A lot of times they'll have a thick or a protruding tongue. The face sometimes is a little bit more flat, and they may have short nose, short palpable fissures underneath the eyes, and then one of the more common ones that you'll see is a simian crease. So if you look at your palm, a lot of times you have multiple creases that go across the palm. They typically will have one large one that goes across the palm, which is called a simian crease. They sometimes too will have a kind of an extra area of skin or fat on the back of their neck, more than an infant that is not impacted by Down syndrome. So if you see these, a lot of times then genetic studies will be done for that baby. The big thing to know about or to consider with those infants with potential Down syndrome is, remember we said cardiac issues are pretty significant. So if you've got a baby that's suspected Down syndrome and you're working in the nursery, then you really want to do a great cardiac assessment on them. Watch them for cardiac issues or respiratory issues, because we know that they are such high risk for developing those issues. So keep that in mind when you're taking care of those patients. Failure to thrive is, I believe, our last concept under this area. So basically it's just decreased growth. It can occur from a myriad of issues, and it's one of these things where we have to drill down and determine why they actually are having the problem. So it could be developmental. It could be some suck and swallow issues. So maybe you've got a baby that just can't mechanically get the suck and swallow of feeding down as they should. That happens with some babies. Most babies it happens naturally, but some just don't for whatever reason. Maybe they have a cleft palate or a cleft lip, or a tongue tie where the frenulum is very tight and they're unable to suck and swallow like they should. Sometimes it's an absorption issue, so they may be eating fine, but they're not absorbing the nutrients for whatever reason. It could be related to nausea, vomiting, diarrhea. We talked about pyloric stenosis last semester. Some of those babies, if they're not caught and treated early enough, can end up being failure to thrive because they're perpetually vomiting all of their nutrition out. GERD, or that gastroesophageal reflux, once again, we're vomiting all of our food out, or a lot of it, enough to really impact our ability to be able to take in and use nutrients and grow as appropriate. Cardiac or lung issues, that kind of can get back to those Down syndrome babies as well. If you've got a baby that's having trouble breathing, they're not going to eat. We always choose airway over eating, and so it may be that they're just not able to take in enough milk or formula or food to be able to support their growth because they're eating such small amounts because they're fighting to breathe. You may have babies that when they start to eat, they turn blue. That can be a sign of cardiac issues. And so then we're going to have a problem because that baby can't eat. So if they're in the hospital and we've observed that shortly after delivery, we can do something about it. If that doesn't come into play until after they go home from the hospital, then the parents may not realize that that's going on, or think, hey, he's fully quit eating. Well, he quit eating because he can't breathe. Because he's having cardiac or lung issues. So those are things to consider. Lastly, sometimes it's related to neglect or abuse or poverty. They just can't get the formula that they need, or they can't feed the baby like they need to. Sometimes it's a lack of education. We've had moms that will feed babies cow milk, even though they've been told, cow's milk is not appropriate for newborn babies. But they don't know any better, and they haven't been taught, and they may be young and unaware, and so that can do significant damage to that baby and certainly cause them failure to thrive. So this is just kind of a hallmark sign of a baby of failure to thrive. They are just small. Now his abdomen is kind of protruding, but his little limbs are very skinny. He looks malnourished and kind of dehydrated even. So just keep that in mind when you see these babies. So other issues, it's not always neglect. It's not always an intentional issue or abuse. Sometimes there's biological things going on. So we have to drill down and find out the reason. So how do we treat these babies? So we want to identify the cause. What's causing this? We really can't improve until we identify why this is happening. Sometimes it relates to diet changes. So maybe they have a lactose issue. Maybe they have celiac disease. There can be some other issues with dietary things that can cause absorption issues.